Welcome back, everyone. Today, I'm so incredibly excited to bring you a guest who is a true advocate for women's health. If you've been following the conversation on HRT and menopause on social media, you've probably seen his name, and for good reason. Joining us today is Dr. Jordan Emont, a highly respected OBGYN who has become a powerful and much needed voice on a topic that has historically been so dismissed. So what makes Dr. Emont so special is that he's one of the very few male doctors who not only supports hormone replacement therapy, but he actively champions it using his platform to cut through the noise and misinformation. So we're going to be talking about a question that so many of you have asked me, you've asked Dr. Emont, I see on social media, HRT for women over 65, maybe over 60. We're going to get into the details, the data, and the truths that every woman should know. Dr. Emont, thank you so much for being here. It's a true honor to have you on the show.
Thank you so much. I'm so excited to be here. I know that it's bright and early for me, but I'm energetic and ready to go. So,
Fantastic. I think we meet each other on the same energy vibe. I love
yeah.
it. All right. So tell us a little bit about you. I mean, as a male physician, you are in a very unique position to advocate for women's health. What inspired you to specialize in this area and speak so passionately about HRT and or lifestyle medicine?
Yeah, absolutely. Well, thank you again for having me on the show. I'm just so excited to be here. Truly, nothing brings me more joy than being able to teach and make something clear that is clearly, something that is very confusing for people. And I think that honestly, that's what really motivated me to go into OBGYN in the first place. I never really thought that I was going to be an OBGYN. And then while I was in medical school, I just fell in love with the conversation surrounding women's health. I love the fact that every single interaction that you have in women's health is an opportunity for advocacy because women's health just is not prioritized in most societies. And so I'll be honest, I never really learned about menopause in my training. And I think that Dr. Haver has very similar stories about how she ultimately ended up in the menopause sphere. But I went from being in my residency training to then working as a general OBGYN and realized that every single one of my patients was asking me about their low libido and their hot flashes and their sleep disturbances and their changes in their periods and their mood changes. And I felt completely helpless to be able to provide information about that. And I think that, two things that motivate me as a physician. One is listening. I think that unfortunately so many women have the experience of going to their doctor and not feeling heard and feeling dismissed. And I think that unfortunately this is especially true within the field of OBGYN. But I think the other thing for me is really prioritizing my own learning because I can't help people unless I'm really learning that for myself. And so I just dove right in and I just, started following all of these really high profile people that I'm sure a lot of your listeners follow. I started reading, I started, doing courses because for me, it felt so unnerving to have so many patients that were struggling with the same issue and not have that information for myself. And the more and more that I got into the field of menopause and hormone replacement, the more and more that I realized that ultimately, this is really more than anything a justice issue. That there is an entire generation of women that I'm sure we're going to talk about today who were denied even the conversation of hormones. And today we're now in a position to be able to actually extend the lifespan for women by providing access to hormone therapy. And ultimately, that is a very personal decision. But I think that every woman, at the very least, has the right to that conversation.
What do you think is actually, what is the hesitancy? Is it I don't think it's specifically a male thing. My experience has been with male doctors, but it's just, I think maybe that's just the statistic. But what is the hesitancy? What is the education shift that needs to maybe change? I mean, you'd be doing all this gleaning, learning, self-education. Is that what needs to happen?
I think it's a complicated question. I think that sort of two things maybe come to mind. One is I completely agree that in a more formal capacity, we really need to be integrating this into the training of every single medical professional. In medical school, there's no teaching about menopause, despite the fact that menopause affects every single specialty of medicine. Every single doctor, every single PA, nurse practitioner, it doesn't matter who you are, is going to take care of women who are affected by menopause, or at the very least, the hormonal changes leading to menopause. So there's no formal process for integrating that into medical education. And I know that, at least in the United States, there are some states that are really trying to prioritize that through legislation, and that is a huge step forward. So that's one. But two is that, unfortunately, in the wake of the Women's Health Initiative trial, so many physicians grew up, myself included, in this era of teaching that hormones were bad, hormones were scary. Somehow birth control was totally fine, but hormone replacement was something that you should absolutely fear and only should be used in the 0.5% of the most severe cases of menopause symptoms. And really, the dynamic needs to shift, that we really need to be teaching hormone replacement really should be the first line for the vast majority of people. And the vast majority of people, especially early in menopause, really are candidates for hormone replacement. So I think that physicians need to teach themselves, but I think that at a more systematic viewpoint, we really need to be bringing this into education from the early stages. And maybe at the very least, just get medical professionals to not be scared, because I think that there's so much fear surrounding this, and that's unfortunately a huge part of it.
I think so. And I think I sometimes wonder, because the frustration is so huge. This guy, he's a medical doctor, he's an OBGYN, for instance, or just your family physician, right? He's getting to like almost 60 years old. He's still part of the whole WHI thing, the trials, and he's come through this whole journey. And he's like, I just don't want to learn this new stuff. I'm not getting to the end of my career. That's how I feel it is. And so that's why, like, for a lot of people that I speak to, we just say, find the youngest people, the latest trained physicians, because hopefully, they have got beyond WHI and it's not going to interfere with their learning. But it is interesting. You know what I want to ask you? On your Instagram, this was so amazing. That's what actually led me to Dr. Emont. So for the listeners, this is very cool. Please share your recent story about your patient that got conflicting advice from a pharmacist, of all people. What happened on that day?
Yeah, absolutely. And unfortunately, this story that I told on Instagram was just one example of a story that happens to me or my colleagues almost every single day. But the story is that I wrote a very routine prescription for an estradiol patch and a micronized progesterone pill for a patient, which is really the most common regimen that we use for hormone replacement after menopause. And nothing in particular. This wasn't a particularly high-risk person, extremely reasonable candidate for hormone replacement. And she got to the pharmacy to go pick it up. And it seems like there's mixed experiences, but typically pharmacists will sit down if there's a new prescription. At the very least, we'll discuss some of the risks and benefits of that. And the entirety of the conversation was the pharmacist just saying, that this patch is just going to cause you to get a heart attack or a stroke. That was it. No other discussion. And what I said in the post is, I don't think it's unreasonable for a pharmacist to have a discussion with patients. I love pharmacists. I think they're some of the smartest people that I know. And my post was not intended to, be an indictment of pharmacists as a field. Yeah. But my bigger concern was that they were saying only this about this one particular medication that is actually remarkably safe. And yet there are numerous other medications that we prescribe. And the example that I gave was thyroid medications, which also can be very safe for most people, but of course can also cause significant risks. And so, for any other medication other than hormones, I'm sure that there is a more robust conversation about the risks and benefits that is happening. And yet, when it comes to a low-dose estradiol patch, somehow this becomes, the worst possible thing that somebody could do. So I just found it deeply upsetting. Again, going back to our conversation about the systems issue, that, this is more that we as a field, as a medical profession, need to update ourselves. You're exactly right. There's always going to be people who are at the end of their career. They're like, I've done my work. I take good care of patients. I don't need to add this in. I don't know if I have a lot of suggestions for how that person can get better. I'm sure that I might feel similarly at some point later in my career. But I think that, we just as a responsibility, we as a field have a responsibility to really update ourselves. And again, to bring a systems-wide view to this, that only women's health seems to be the area where it's okay to give this type of scary, paternalistic information. And yet for any other medication, a pharmacist or anybody else would be, pretty comfortable at least having a basic understanding of the actual risks and benefits of those medications.
Yeah. Doctor, what happened with the patient? So the patient comes back to you like, what the heck? And now you're going to do a whole re-education and placate this person. What happened?
No, so that was exactly what happened. And this patient, happens to be somebody who is at baseline very anxious about starting new medication. So even just the initial conversation surrounding hormones, was a long one, and we really hashed it out, which is what should be happening. And of course, exactly, she picked up the patch. She never put it on until we had a chance to meet again. And I told her, don't worry, everything that they told you is not up to date with our current literature. And ultimately, she ended up starting the patch and ended up feeling, great, as many people do when they start hormone replacement for menopause. I did also speak with the pharmacy. I wasn't able to speak with the pharmacist myself, but I was able to, kind of file a formal complaint with the manager. So I think that, through these stories that we're sharing, and hopefully, through kind of that, again, that individual level advocacy, both with patients, but also with the institutions, I think that we are slowly making progress. And I really do see it happening. And even for somebody like me who relatively recently went through training and then now to be in this position of, somewhat authority to be able to speak about this, I think is just a testament to how much you can learn just by really investing yourself into this and really deciding that we really need to prioritize women. We can't be in a position of just deciding that this isn't a field that we care about.
Yeah. Oh, it's incredible. I think that so many times, maybe you and I and people we talk about HRT all day and midlife and menopause, etc. So our Instagram feeds are rife with tons of Dr. Mary Claire, Dr. Von der Wright.
Exactly.
So we getting educated and seeing the latest information. Even my podcast, everything that comes to me is all this stuff. So for the end user, the person that is coming to see the doctor, often these people, and I'm not saying all, but a lot of the people, I think it's got to do with an age group as well, where slowly a lot of people are using more social platforms, and so they're getting information. But there are people who are not on there and they're not getting all the feeds. We think they are because we see it on ours. It's not what they're seeing. They are not getting information. They're not advocating for themselves. There's so many topics that I'm suddenly realizing, wow, this is something new, which I will just quietly whisper. Oh my word, E3, estriol for the face, not happening in Canada. I want to know more. But anyway, we have questions. So I want to talk today about that burning question. Many women have been told there's an age limit for starting or continuing HRT. Can you talk about the data that we have, the safety, efficacy of HRT for women over 65? And I think what is nice for the listener and for me as well, I want to know what is happening physiologically in my body when I'm post-menopause. What's happening, and then tell us about the HRT.
Yeah, excellent question. Maybe we can start with the second half of your question, because I think it's a nice intro into why we use hormones generally. So, leading into menopause, there is complete hormone chaos. The ovaries are trying their best to keep up with the demands of estrogen for the body, and they are increasingly unable to do so. And so what happens is that hormones, estrogen might be very high one day and then it's very low the next day, but overall production is going down. Once we pass menopause, which is officially 12 months since your last period, the hormones start to stabilize, but they stabilize at a low level. So estrogen production is essentially zero. And maybe I should be more specific to say estradiol production is essentially zero. Estrone, which is another kind of estrogen, actually tends to be a little bit on the high side because that is the estrogen that is produced in typically fat cells in particular, but has a much less potent effect. Progesterone is actually zero because progesterone is only produced after ovulation, which is no longer happening. And testosterone production also goes down significantly, although follows a little bit of a different pattern. Because of this, we start to see massive changes across the entire body. I think that Dr. Haver has said this best, which is that every single cell in the body has a receptor for estrogen. In fact, estrogen receptors are truly the original sex hormone receptor of the body. They've been discovered in, these ancient, lizard species. It's remarkable. And so because of that, we start to see effects on the brain. We start to see effects on the metabolism. We start to see effects on the bones. We start to see effects on the heart and blood vessels. Every single part of the body is affected by no longer having estrogen. And this is what leads to the symptoms of menopause. So hot flashes, vaginal dryness, mood changes, all of the things you typically hear about. But it also leads to the long-term health consequences. So we start to see stiffening of the arteries, which leads to an increase in heart disease. We start to see bone turnover increase, so osteoporosis develops. We start to see things like diabetes and high cholesterol develop, almost as a response actually to the low estrogen. So that's really what's happening in the body and why a lot of these changes happen, because estrogen is the primary stimulus for maintaining a lot of those tissues to be healthy. For the second part of your question, there is no question that starting hormones earlier provides more benefit. And so that's why I very strongly encourage patients and anyone to seek out help on the early side. We know that these hormonal changes can start even in the late 30s for a lot of women. And so seeing a specialist, seeing somebody who really knows what they're doing and starting to have these conversations on the early side is only going to provide benefit. Now, you're exactly right. Typically, we say that there is this 10-year cutoff for starting hormones, or at least that's been the historical recommendation. And where that really comes from is the Women's Health Initiative study, which is actually a remarkable study. I think that it gets a really bad rap. It is still easily the best study we have on hormone replacement. It's just unfortunate that it was completely misrepresented. And it's also unfortunate that the hormone regimen in it is no longer the hormone regimen that we typically use. But as far as a general overview of the benefits and possible risks of hormone replacement, it's a remarkably well done study. So in the Women's Health Initiative study, what they found is that older women, which was a predominance of the folks who were enrolled in the study, who used hormone replacement, ended up having increased risks, particularly for heart disease, which is why the study ultimately was stopped. In response to that, a lot of organizations created this arbitrary rule of saying that within 10 years of menopause or by age 60, the benefits likely outweigh the risks, because we saw that for younger women in that study, there were benefits for heart disease, there were benefits for bone health and other factors. And so that's where this originally comes from. The other thing to keep in mind is that that is typically the age group that is going to have the most symptoms. So the vast majority of women who are going to have hot flashes in particular, it's going to be within that 10-year window. What we forget, though, is that 40% of women will have hot flashes into their 60s. 15% of women will have hot flashes into their 70s. 10% might have hot flashes for the rest of their life. And that's just one aspect of the symptoms. We know that menopause causes so many other symptoms. So I think that there are very reasonable reasons to think about starting hormones later if you never had a chance to start them before. But I do think you have to be very intentional about what your goal is. And we can get into that if you'd like.
I think that's great. I think that I have a lot of people that I connect with, especially in my yoga situation. I have a lot of seniors that I teach. And so it's like, I used to use hormones. I stopped because that was kind of probably part of the WHI trial. Can I start again? Because I think the big thing we need to talk to is, and I think for the listeners is, I know that there are massive benefits. I am thrilled I can use HRT. I mean, I saw a difference in 2 days.
Yeah.
Getting onto it.
That's not uncommon that people have that quick of an effect.
And I don't want to say that that's going to be for everybody, but I just want to tell you guys, but the thing is, I did all the research. I did the gleaning, the learning, everything. So now I've got these women who are like, well, gee, you feel so great. I want whatever you're on, right? And so somebody who's now 65, can she say, okay, I don't need progesterone because I'm not ovulating. What is she going to take?
Right. Yeah. So again, I think coming back to this idea of what somebody's goals are. So, in my view, the most compelling reasons to start hormone therapy after 60 or outside of this 10-year window are for symptomatic relief or for osteoporosis prevention.
Right.
And that's really where we have the most positive data. For cardiovascular disease, we do see significant benefits for cardiovascular protection when started early. After age 60, honestly, the data are a little bit mixed. So again, the Women's Health Initiative study showed an increase in cardiovascular disease, particularly in the first year of use for women who were outside of that window. There have been other studies that have shown similar findings. The interesting thing is that in one of the studies, which is the HERS trial, where they actually looked at people who had already had a cardiac event and then used hormone therapy afterwards, what ended up happening? They saw this similar trend of an increased risk of repeat heart disease in the first year. But once they started to get into year 4 and 5, that effect actually started to even out. And so it suggested that maybe there is actually eventually a positive benefit that it's accrued. This is the real trouble. Those studies used oral estrogens and synthetic progestins as the form of hormone therapy, which is rarely what we use these days. And the reason why this is important is that we know that oral estrogens in particular increase the risk for clot formation, which is typically the cause of a heart attack or a stroke. Dermal, so through the skin estradiol that we use most commonly today, does not increase this risk at all. And we have great studies like the ESTER trial, which showed that even in people who are at high risk for developing clots, they have no increased risk of developing a clot when they use transdermal estradiol. We don't have any trial like the Women's Health Initiative's trial for using transdermal estradiol. And the data at this point would really suggest that there's really no increased risk for cardiovascular disease by using transdermal estradiol. But I will say that the preponderance of the data also suggests that there probably is not much of a cardiovascular benefit once you're outside of that window. And the reason for that is that by the time somebody is 60, 65, they've probably already had the accumulation of plaques in their coronary arteries. They've already had stiffening of their blood vessels. The benefits that estrogen would bring to try to prevent those things from happening is probably not going to exist as much. I would make the argument that if there are other compelling reasons to start hormones, again, especially for symptom relief or for osteoporosis, and somebody is otherwise pretty healthy and they're going to live a long time, my guess is that we would probably eventually see a benefit because at least you're maybe stopping that process to some extent. But we really don't have data to suggest that. I would typically not suggest that somebody start hormones after 60 just because they want a cardiovascular benefit, because we really don't have studies that say that. Now, osteoporosis is a completely different story. The Women's Health Initiative study, one of the best findings from the Women's Health Initiative study is that regardless of what age you are, there is a benefit for your bone health. It decreases the risk of osteoporosis, it decreases the risk of fractures, and a hip fracture in particular, which also goes down with the use of hormone therapy, can be catastrophic. 30% of people who have a hip fracture die within a year of having their hip fracture. It is one of the worst things that can happen to a person. And women are much more likely to get hip fractures. So I think that is a very real consideration, and it is one of the explicit FDA approvals for the use of hormone therapy is osteoporosis prevention. So that is an extremely compelling reason to potentially start hormones later in life. To go kind of to your other question about if you're already taking hormones, can you continue them? I think that's another common question that comes up. Yeah. So actually in 2024, there was this massive study of like 10 million women on Medicare who were using hormone therapy, and they really tracked their outcomes and they looked at what forms of hormone therapy they were using. And what they found is that women who continued hormone therapy had across almost every single marker an improvement in their health. So I'm forgetting the exact numbers, but I think it was an 11% decrease in overall death So women who continued their hormone therapy actually lived longer than women who didn't. We have other studies that say that, like the Danish osteoporosis study as well, and had decreased risks of certain forms of cancers, had decreased risk of osteoporosis, as mentioned, decreased dementia risk as well. So very, very, very compelling reasons to continue. Everyone's always concerned about breast cancer as well. In that study, they did actually see a very slight increased risk of breast cancer when continued. That being said, I think it needs to be taken a little bit with a grain of salt because it looked across a variety of different hormone therapies. And we know that, for example, the synthetic progestins that were used in the Women's Health Initiative study do increase the risk of breast cancer. But we have excellent data that shows that the typical transdermal estradiol and natural micronized progesterone that we use does not increase that risk. So the best data we have would say that you really don't have to be too concerned about breast cancer. If somebody was very high risk for breast cancer and they were very nervous about it, then there could be a reasonable conversation surrounding that. But again, I would never tell somebody that they should stop taking hormone replacement if it's doing so many other benefits for them, simply because of a concern for breast cancer. The risk is so low relative to the risk of other things happening.
Tell us about testosterone over 65.
Yeah. So there's really not a lot of data. But the data that we have about testosterone overall would suggest that it is extremely safe. We know that testosterone, particularly when we use it in like a cream, like through the skin again, does not increase the risk for heart disease, does not increase the risk of breast cancer, and then there's so many positive benefits that can come from testosterone. So we know that testosterone can help with libido, which is, one of the most common reasons that it's typically started, but it can definitely help with cognitive function and brain health. There's some studies that suggest that it can decrease the risk of dementia. There's some studies that suggest it can decrease the risk of osteoporosis by improving, muscle mass and strength. So I love testosterone. We have no really good studies that have been done that have looked at exactly this question. So there's nobody who's ever actually done a research study that says when you start testosterone for the first time after age 60, what happens? But we do have very long-term data on testosterone safety, particularly from trans men. And so trans men are, really people who are in a female body that are using 10 times the dose of testosterone that we would ever use for menopause hormone replacement. And we see extremely robust safety of testosterone in those folks. So Dr. Kelly Casperson likes to talk about this all the time, that there's really no other medication other than testosterone that we give people 10 times the dose that we would ordinarily give and have a good evaluation of what their outcomes are other than testosterone. So I think testosterone is a great choice. I think there's so many benefits. Again, no explicit studies that have looked at it, but the best data that we have would suggest that it is a very, very safe choice.
Yeah, I'm loving the testosterone. And I think what is very interesting is the stigma is always, it's to do with libido. Absolutely, it's one of the symptoms. But I think, and that's why it's such a problem to get this thing on the counter. So you're getting it from your compound pharmacy. I've started off at 2.5 milligrams. It also rolls out like a little deodorant bottle and you rub it onto your skin. I think for the listeners, some people just have no idea, like what form am I taking this? That's often why I get so direct and open about it. I don't mind. But what really was cool for me was I would have this extreme fatigue. And I'm high energy, go, go, go all the time. So I do operate at like this level up here. For the podcasters, you can't see what I'm doing with my hand. My hand is way above my head. I operate at a high level of vibration, right? And high energy. And so, I'm assuming it is the testosterone, but I just don't have that crazy lolling in front of the TV. Like I cannot keep my eyes open. So, I'm waiting to see if I'm going to have other positive benefits from testosterone, but for now, no, nothing crazy and no weird hair growing in odd places.
Right.
What's with people?
Yeah.
Guys, like I haven't had that yet, so just saying. So
it is definitely, I would say, the main primary documented side effect. But I agree that I think it tends to happen when people are using slightly higher doses than where you're at. I like to do the approach that you're doing. I usually start like at a very low dose. We go up very slowly. You know, we never want to get into a range where somebody's going to have side effects. And if testosterone is done right, people should really not have any side effects with it.
I love that. And that's the approach. I think it's looking at the patient holistically and going, okay, so we're going to do this for you. Not everybody is the same. And I think that's the key with even our menopause symptoms. I want to talk about, I want to know, was it Dr. Mary Claire Haver, was it Tamsin Fidel that reposted your story and you just exploded on Instagram? Who was it? Which doctor?
It was Dr. Mary Claire Haver. And
lovely?
then she's amazing. I know I've actually never met her personally. And then
That's got to happen.
Yes, I genuinely hope so, because I admire her so much and I just think that she's done so much for this field. And also Dr. Louise Newson also had reposted one of my stories, and I mean, I'm eternally grateful to everyone who has shared my story. You know, off camera before we started, I said I don't think I'm saying anything that's particularly compelling. I think that there's a lot more smart people and knowledgeable people and experienced people who are on social media who are talking about this. And I feel very grateful that people, you know, have found my content to be helpful. But I'm just extremely grateful to the two of them for sharing, because I don't think that my follower growth would have happened without that. So,
Dr. Emont, I honestly, you know what, when I saw the post, I think what it meant for me was that, hey, I've got a guy in my corner. And I didn't want to bring it up and say, oh, it's a male thing, but I actually think it is. I think that we don't feel supported by our men, and it's not just men, but it's great to have a guy saying this. And I think that you're advocating for women's health. And also, what does it say for the situation we're in? It exploded because people are like, oh my gosh. And your education aspect of your Instagram is fantastic. Like, I can't wait to see what's on the next morning. Oh, this over 65. Now we're talking about testosterone or whatever. So we just need more people like you. So thank you very, very much.
That's very sweet. Thank you. I mean, I do agree that I think that there are not enough men in this field. And I can tell you for sure, if women are not talking about menopause enough, then men are definitely not talking about menopause enough.
Right on. 100%.
You know, I think that we all need to be a part of this. You know, at the end of the day, obviously menopause is affecting women, and the symptoms are experienced by women's bodies. But the experience of menopause is really across everyone, right? People are having symptoms that is then having effects on their relationship, and that it might be affecting their sex life, and it might be affecting the way they interact with others. And there's so many divorces that happen in midlife. It's one of the most common times, and a lot of those relate to changes in relationship dynamics and changes in sex life. And it's so sad to me for two reasons. One is because we have treatments for this. This shouldn't be something that a woman is suffering through unnecessarily. But more importantly, one of the most common things that I hear from my patients is they'll be talking about how sex has become very painful, and we'll be talking about vaginal estrogen or something like that. And then, they'll be talking about some relationship problem that is brought up, and I'll say, oh, well, have you told your partner that, this is uncomfortable, and that, you don't want to do this, or you need to wait on this. And, they'll just be like, he just doesn't get it. And it makes me so sad, because again, this should be something that in every relationship, in every opportunity, we should all be open about discussing. Nobody wants to have sex if it hurts, or at least, you should be able to choose if it hurts. And so I think that, these conversations need to include men, because I think that men also need to be a part of understanding what is going on, and why changes are happening, and, how treatment can be accessed. I think that this is the same rule that should apply to doctors as well, which is that, again, so many women feel so dismissed when they go to their doctor. And I think that there is a really important role of physicians in having medical knowledge, but I think being a good doctor is mainly just being present and listening. And that goes such a long way for so many people. So many women, go from doctor to doctor to doctor. I think it's like 7 doctors is the stat that women need to access before they get a good conversation about menopause care. That's absolutely unacceptable in my view. And I would say that the same thing needs to apply to men as a whole, that, we should not be in the position of saying, oh, my wife is going through this thing and it's really annoying, right? We should be the ones who are, saying like, you need to, figure out how we can get treatment for this. And, I'm here for you. I'm here to help you. How can I make this a better situation for you? I want to be present and listen because that is what preserves relationships, and that also is what helps women ultimately.
Yeah. Have you got any tips for us? A woman comes in to your practice and you're like, oh, I think I'm in perimenopause. And I'm going through these symptoms. I don't know much about it. Give us some tips. Like, tell us. I saw on your Instagram once, I think it was something about flossing your teeth. And I was like, actually, I don't know if the listeners, I've even discussed it once.
Yeah.
Bleeding gums is a symptom.
Yeah.
What other tips do we have? So floss every day. So anyway, if you didn't know that, I know. Aha moment for some right now.
It's a great question. Well, first of all, I mean, obviously I'm a huge advocate for using hormones, but I don't think that hormones are necessarily going to be the right choice for everyone. I always start with a conversation about lifestyle. This is for 2 main reasons. One is that hormones are a miracle. They're incredible. I think that most people are candidate and should really consider it. But I always say you can't out-hormone a bad diet or a bad exercise regimen. And you can be using hormones, but if you are not keeping track of your health in other ways, you're not going to feel as well and your health is going to suffer because of it. So if somebody is not doing any kind of exercise, at least can we get you walking? Can we, get you doing a 10-minute walk every day and then, build it up over time and then eventually incorporate some weight training, which is so important for women's bone health in particular. Diet also goes along. I think that there's so many diet changes that come during the perimenopause transition. What's the most common thing that almost every single woman says during perimenopause and menopause? All of a sudden, I put on 10 pounds, I put on 20 pounds, I put on, whatever amount of weight. I can't get rid of it. And, yes, there's a hormonal aspect to that, but it's also, the things that somebody might have been able to get away with diet-wise in the past don't exist, once we get to midlife. And this is true for men too. So it's not only women. But I think that, that's always where I start in terms of tips is how can we integrate at least basic lifestyle changes that are going to be healthy for you and integrate into your life well. And then let's also talk about some of the other factors. I also tend to think about these things more in a let's add things to your life rather than let's get rid of things from your life. I think that so many people, go into a diet by saying, okay, I can't eat cake anymore, or I can't have this. But instead it's, no. Let's figure out how do we add protein into your diet? How do we add fiber into your diet? How do we add, polyphenols into your diet and, healthy cruciferous vegetables? That's, I think, a nicer way of thinking about it. Because nobody likes to lose things. Everyone wants to gain something. They want to win. And so Absolutely. I think that that's exactly, kind of where I start. The flossing, I think, is great. I mean, you're exactly right. Bleeding gums can definitely happen. That happens during pregnancy too. And I just had this conversation with a patient yesterday that I think a huge part of it is that I think the gums were going to bleed anyways. It's, just that the inflammation is now worse because of some of these hormonal changes. And so, yes, dental hygiene is very important. There's really good studies that say that one of the best ways you can prevent dementia is to have good oral hygiene. And so that chronic inflammation, from gum, from gingivitis and, dental issues, that can lead to a lot of chronic issues. So I think flossing is great. And there's many other things.
And I think we should also do that other flossing. Okay, that's old school.
Yeah.
We need to get up and dance. You need to do something.
I completely agree.
To move.
Yes,
Guys,
that's exactly it.
I love the concept about adding and not subtracting, because the big thing is, it's amazing what the brain does when you say you can't have something. It's like immediately, oh my gosh, now all I want is bread. We're
Yes.
cutting out carbs for the rest of our lives. Oh my gosh. And now there's no alcohol. Now there's no coffee. And now you can't have charcuterie boards because it's processed meat. What is left in life for us?
I know,
But
that's exactly
whatever,
right.
You know, so it's true. But I think that is so spot on, is how do we add these things? And also not cut it out completely. Have those one or two things and not... I have this thing where I'm like, can we just not do the Monday thing? It's not about a Monday. It's like, it's okay. We don't start on a Monday, we start right now.
Yeah.
You know?
Totally.
And I love that. Listen, Dr. Emont, thank you so much for your time today. But mostly actually for all you do for us. You've blown up and I'm so happy because I think you're fantastic. Please don't stop what you're doing.
Thank you.
Thank you for your great Instagram account. Like, it's such valuable content. Follow Dr. Emont on Instagram. He's going to blow up a little more now. So please keep it coming. I really wish you truckloads of success in spreading the message that is about women thriving through midlife. We need you so badly. There is hope. Women out there, if you're listening, we do not need to suffer. Hallelujah. Thank you, doctor.
Thank you so much. This was so much fun, and I'm just so excited to be able to share this. Can I add one last final tip?
Please, go ahead.
So in all of this discussion about hormones, I think that I can't leave this conversation without talking about vaginal hormones, which is that regardless of what age you are, what medical problems you've had in the past, even if you've had breast cancer, even if you have breast cancer, you can use vaginal hormones. There is the most robust safety data on that, and it prevents UTIs, it makes sex more comfortable, and it prevents dryness and further discharge in the vagina. So it is one of the best things you can do for your long-term health. Use it. Don't be afraid. Don't even think twice about it. It is always a good choice. So.
Fantastic. I love that tip, and that is super exciting. Please go and speak to your doctor. Get yourself armed with information before you walk in that door so that you know all about your body. And so to the listeners out there, thank you so much for tuning in. I will bring the people to the podcast. If you've got burning questions, drop them in the comments. We'll get the people to talk about it. Maybe we get Dr. Emont in again. I think there's still many more things I want to talk
Absolutely.
about, like micronized progesterone. I still want to hit that topic. So please subscribe to the channel to get the latest updates and these awesome conversations as they upload.